joining today's webinar. This is the Introduction to Health Economics for Public Health. We're so glad you're here. I'm Victoria Chalette. I'm representing the California Association of Public Health Economists. I'm also the Senior Health Economist for Santa Clara County Public Health, but in today's role, I'm representing CAPHE. Officially, CAPHE is a professional community of health economists and public health professionals working across California's local health jurisdictions, as well as CDPH and academic partners. Our mission is to build economic analysis capacity within public health practice. So this is our first webinar. We invite you to attend others as we share them on our site. We have 2 additional ones scheduled, and I will reference them during today's talk. So here are our 4 learning objectives for today. I just want to walk through each one. First, we're going to define health economics. And I want to be clear up front. Health economics is not about money alone. It's really about decision-making under constraints. And that's something that every single one of us does every single day. Second, we'll cover 3 foundational concepts: scarcity, trade-offs, and opportunity costs. These are, I promise, very intuitive. You already think this way. We're just going to put names to the ways that we think, the thinking we're already doing. And third, we'll look at how economic thinking can actually strengthen your program decisions and make them more defensible. This is the practical payoff component. Like, how does this help you on Monday morning? Finally, I'll point you to some resources so you can continue learning more about health economics. CAPHE has free tools, and this webinar series continues through the year. So as I mentioned, this is an introductory course. No prior economics background is required. So this slide is one of my favorites because it does validate what we already know and about the way that economics can complement existing public health sciences, particularly epidemiology. They both work together to really inform better decisions. So in epidemiology, our focus is already on rigorously thinking about evidence. We ask, does this intervention reduce disease? What's the effect size? Is the study well designed? Who benefits? And that's a very powerful perspective to take when looking at these kinds of interventions. Economics adds a complementary set of questions. So just focusing on what is the best use of limited resources, what is the cost per outcome, and thinking about the opportunity cost of that. What are we giving up to do this particular intervention, and how do we maximize impact? And so I'll open it up if anyone has any examples they'd like to share about a time, when economics really helped make the case for a program or not, in a way that was sort of different from its direct impact on disease burden. Oh, please go ahead.
I've got some little bell that goes off in my head. I'm not sure if it's a medical condition or not, but each time I hear people talking about things that make their job difficult, it often seems to me like they're talking about limited resources. Like, hey, we don't have enough money to do everything, or we don't have enough doctors or nurses or supplies or whatever. Do you see this as a fault of economics, or do you see economics as being able to help if people are not able to do everything they want to do at their public health unit?
I think that's a really good point. That is definitely the economic lens. It doesn't diminish the effectiveness of any one program on its own, but it does help compare to alternatives, because we are almost constantly dealing with a chronic underprovision of resources to deliver everything, and making choices about what is of highest priority or highest impact given the finite resources. So yeah, that's, I think, exactly the bell is a good way of putting it. The lens that economics can bring to public health questions. Okay, so let's start at the beginning. What exactly is health economics? I think sometimes it has a negative or slightly negative association with just the word economics, where it tends to be construed as a means of cutting budgets or putting dollar signs on human life, or letting bean counters make health decisions in a way that feels insensitive or disconnected from actual patient experience. But health economics is not really about those things. And I want to make the case here that what it actually means. So for us, it's really the study of how individuals, institutions, and society make choices about allocating those scarce resources to improve health and to impact that. Choices about allocating scarce resources doesn't necessarily mean maximizing profit. That's a business question, or also minimizing costs. That's an accounting question. But the best choices, given that we can't possibly do everything. Um, do we invest $1 million in a new vaccination program or expand mental health services? Both of those are great areas to be investing in. They're worthwhile. They save lives. But if you had to choose, and splitting isn't necessarily the optimal choice, or at least you have to make a good way of splitting it so that it's meaningful, health economics can help you kind of make that decision. And this is something that I think public health has been asked to do many times over. So in 2023, ARPA funding came through as a one-time payment to counties. There was a whole range of things that the money was used for. Some invested in community health worker programs, others expanded telehealth infrastructure, some expanded housing navigation services, citing it as part of the public health domain. And every single one of those was a reasonable choice. And each county had to weigh their specific community needs against their specific budget. So I'll just pause here and see if anyone has any additional thoughts.
Dr. Cholet,
Yes,
uh,
go ahead.
is it possible just for us to do like all of the things that work and then just like not do the things that don't work? Could we just worry about things that way by just spending on the things that work?
This is an interesting question. I think in part it's questioning under what circumstances different interventions work is part of it. Um, and also that interventions can work independently of each other for different kinds of outcomes. And how do we identify what those benefits are and talk about them uniformly so that we can compare and make a choice about what generates the best outcome for everyone, or the highest amount of benefit that we could extract for the money that we or resources that we have. So I think that's a really good point. So why is health economics so important for public health? I'll make 5 reasons here, but I'm sure that if there are others, we should talk about them. The first is that our resources are always limited. You know, whether budgets are growing or shrinking, even in a good budget year, you can't fund everything. California local health departments collectively spend about $4 billion annually. And that sounds like a lot, but when you spread that across 40 million residents and hundreds of health priorities, it gets very thin very fast. Um, and second, decisions affect population level outcomes. So when a hospital makes a poor investment, or a few hundred patients are affected, arguably. When a county health department misallocates resources, though, tens of thousands or hundreds of thousands of people may not get services they need. The stakes are very high. Um, and third, and this one is, I think, increasingly important, stakeholders want to see evidence of value, right? It's data is coming in from all kinds of places, which is a really exciting time to be in research right now. But actually interpreting that data, giving a full picture of what the impact or what the potential impact is of decision making, has a lot of people asking, what is the return on investment? How does this compare to other alternatives? And what would happen if we were to cut this program or expand that program? And so that economic language to answer those questions effectively is, I think, a real contribution that the field can make. And finally, as we noted before, um, economic analysis lets you compare interventions that seem incomparable. How do you weigh tobacco cessation programs against childhood-led prevention programs? Those are not the same populations or outcomes. They also have different timelines for when impact would show. So economic analysis really gives us that common framework. And finally, certainly right now, it has never been more critical to look to external funding to support our programs. And that kind of funding, those grant applications tend to be more competitive when we can talk a little bit about cost effectiveness data, or at least a discussion of economic value to make applications stronger. So all reasons to think about these things. I don't know if anyone has other thoughts about them, or if you've ever been asked to justify a program's cost effectiveness. I'll just pause. Okay, so scarcity is a pretty foundational concept in all of economics. Everything else sort of can flow from this, arguably. Our definition here is fairly simple. There's unlimited wants and needs, but limited resources. In public health, resources is the funding, the staff, time, the facilities, even to some extent the political capital. It's finite, and you might think, for example, that there's budget authority for 2 new positions. Different divisions could make a case, a very strong case for each of their respective needs. Suppose the communicable disease team wants an epidemiologist to handle surge and STI cases, or the chronic disease team wants a health educator to run a new diabetes prevention program that was previously flagged as a priority, or the community health team needs a community health worker to do outreach in neighborhoods that were identified as underserved. All three are legitimate needs, and all three would improve health, arguably, but if you can only hire 2, someone is going to be disappointed. So how do you decide? You could go with the loudest advocate. You could rotate who gets priority. You could default to whatever you did last year. Or you could think systematically about which 2 of those 3 positions would produce the most health benefit per dollar of salary. And that's last one is the health economics piece. It doesn't make the decision easier, but it does make it defensible. And so I think that this is why we've made it our first concept. And just as a real world California example, after the 2011 realignment transferred public health responsibilities to counties, many departments had to make exactly these kinds of choices with reduced state funding. And that meant needing a framework for prioritizing, even in an informal one, to make better decisions than just straight cuts across the board. So um, the point isn't that economics necessarily has a formula that is going to make these decisions easier. It's just a way to be a bit more deliberate about decisions instead of reactive. I'd like to use this next phase of our talk to go a little deeper into these concepts that form our foundation for economic thinking. And these are some tools that you can start using immediately, even without a formal economic analysis. So if you remember one thing from today's entire webinar, I hope it's this one, opportunity cost. Opportunity cost is formally the value of the next best alternative that you give up when you make a choice. It's not just the dollar cost, it's what else you could have done with those same resources. So as an example on the slide, if your team spends 6 months developing a diabetes prevention program, the opportunity cost is whatever else that team could have accomplished with those same 6 months. Maybe it was launching an opioid response plan. Maybe it was conducting a community health assessment that was due. And so that is the trade-off that we're referring to. To give a really tangible example, suppose a county spends $200,000 a year on a smoking cessation hotline. The direct cost is that $200,000, but the opportunity cost is everything that $200,000 could have funded, whether that's 3 community health workers or a childhood asthma intervention or upgraded data infrastructure. None of that is to say that the smoking hotline is a bad investment, not necessarily, but you can't just evaluate it by asking, does it work? It's also about asking compared to what? Because every dollar that we're spending has the potential to be spent somewhere else. It's not like we have excess funds that we're carrying from one year to another. I don't know if anyone else has an example of where opportunity cost of a program maybe wasn't obvious until someone pointed it out, or an example that they really like to use when introducing this concept. I'll move on to the next. So four trade-offs come up in this idea of opportunity cost in almost every public health decision, and like to walk through with an example. So the first one is breadth versus depth. And you can imagine having funding for a home visiting program. You could serve 500 families with monthly visits or 100 families with very intense weekly visits. The evidence might show that weekly visits are more effective per family, but you would reach 5 times fewer families. So the question then becomes which is better? It really depends ultimately on how severe the need is, how much intensity matters, and what the community looks like. If weekly isn't feasible, if the need is more on a monthly basis than a weekly, that does tend to help tip the scale. We also talk a lot in public health about the difference between prevention versus treatment or prevention versus intervention. It's a classic health dilemma that I think resurfaces at least several times a day when we talk about it. Program planning. Um, During the opioid crisis, counties had to choose, do we invest in prevention education to keep people from starting opioids, or do we fund naloxone distribution and treatment beds for people who are already addicted? The prevention investment pays off over years, but both are essential. And when budgets are tight, we do have to choose between allocating between the two. There's also equity versus efficiency. This one's important. It's the most efficient strategy is the one that produces the most total health per dollar, but it may completely miss communities that need the help the most. So, for example, a countywide social media campaign about flu vaccines might be the cheapest way to increase vaccination rates overall. But it may not reach people without internet access, or people who don't speak the language in which the ad is run, or people who distrust the health system. It doesn't really get at those groups that are the least likely to be, or the most likely to be missed in such a process. And so reaching those populations does cost more. So an economist would say there's a trade-off between maximizing total benefit and distributing the benefit equitably or fairly. And then finally, we think about short-term versus long-term. Early childhood programs are a good example of this, I think. Investing in prenatal care and early childhood nutrition may not show measurable returns for years, for decades potentially, but the long-term payoff is enormous. Reduced chronic disease, higher educational attainment, lower incarceration rates. Um, and part of that challenge, as I mentioned earlier, like political will is a finite source. Elected officials serve 4-year terms, and they may want to see results now or within their term before they go out on a limb to argue for massive resource reallocation. So I just want to emphasize we're not positing that we have a universal right answer to these questions. It's a balance between that really depends on community values and specific context and what the evidence shows. Economics doesn't tell you what to value. It just helps you be clear about the trade-offs that you're making. Um, so I don't know if people have thoughts about out of these four trade-offs, which ones come up most often for them in their work. Um,
I think these are really interesting trade-offs. And I sometimes wonder about whether public health is a very large discussion about bullet number two, just public health in general versus, say, funding hospitals or funding acute treatment versus funding things that if you succeed, you'll never see the disease or the condition.
this is a very good point. It also comes up when we think about partnering with community-based organizations. Even if the public health department intention is to focus on upstream
Mhm.
prevention, our community health partners are very much thinking in sort of the treatment and intervention space most of the time, because there is a need to respond to what's right in front of them right away, especially if the grant cycles are really leaning more towards intervention rather than prevention. So reconciling that is also one of those practical challenges that um, certainly prior to working in the public health space, I didn't fully appreciate.
Really interesting. It
Um,
makes me think there might be a link with bullet two and bullet four.
I agree. Yeah. I
And
would
I
say
think
so.
in the chat, there's a comment as well.
Oh, yeah. Oh, yes. An upstream and downstream framework is exactly relevant here. Yes. I can share that link out with a follow-up from the webinar. Thank you. All right, so the next key concept is marginal thinking. It's one of those concepts that sounds academic, but is incredibly practical. The core idea of this is, instead of asking, is the program good or bad? It's to ask, would one more unit of this program be worth its cost? So I'll use the example on the slide. Suppose we have a team of 4 community health workers on the team, and they're doing great work, and someone proposes hiring a 5th. The question is, should you? If we think, it depends. So if the first 4 CHWs might each carry a caseload of 80 families, and adding a 5th would only allow us to expand to 40 families because there's not enough need, or because most of the geographic area is covered by the staff that's in place already, or suppose high priority families are already enrolled, and so we've exhausted, we'd have to change eligibility criteria to really fully staff that 5th person. The 5th community health worker would cost the same salary, but would ultimately produce less impact than the first 4. They would not have a full caseload then. The question then becomes, does that mean you shouldn't hire them? And the answer is not necessarily. If the 40 that they're serving are harder to reach families, who are the ones who need the most, who need services the most, that's helpful to know. But you do have to know that. You have to know what is the marginal return, and it's different from the average return. So just as a California specific example, many counties expanded tracing teams during COVID. And so you can imagine that the first 20 contact tracers might have been able to reach 80% of cases within 24 hours as a scenario. Adding another 20 might have only bumped that up to 85%. And another 20 on top of that might have gotten us up to 87%. They're not actual numbers, it's just as hypothetical. But basically what I'm arguing here is that each additional group of tracers cost the same, but produced a smaller and smaller gains. And this is what economists call the diminishing marginal returns. It doesn't mean the program is bad. It means that at some point that next dollar might be better spent on something else. So when we're thinking about defending budgets or proposing changes to budgets, marginal thinking helps identify where the cuts would hurt the most and where additional investment would help the most. So instead of saying we need more money, it becomes an additional 100,000 would allow us to serve this many more people and prevent this many more cases. And that can be a much more compelling argument during these times. Okay, I want to shift from concepts to tools. These are sort of the formal methods that health economists use to evaluate programs and interventions. There's sort of 2 broad families of economic analysis, and I want to make the difference clear here. So to start, there's the cost analysis. And this is where most people start. It's completely valid to ask, what does it cost? You know, what is the cost of illness? Studies estimate the total economic burden of a disease. For example, diabetes costs California an estimated $39 billion annually in medical expenses and lost productivity. That number is very useful for advocacy. It shows the scale of the problem. When we think about budget impact analysis, this is estimating what a new program would cost a department's budget. So for proposing new initiatives, it's vital to know for how long and what is the budget impact. Similar to cost minimization, when we think that we have 2 programs that produce the same outcome and we're optimizing that benefit, we may want to think about which one is the cheaper one. And on the right side, value analysis. This is where economics, I think, can really add a lot of power to some of these discussions. So it's asking not just how much something costs, but is it worth it? Cost effectiveness analysis compares cost to health outcomes. Cost benefit analysis converts everything to dollars across different outcomes so that we can compare apples to apples. and a return on investment expresses value as a ratio. So many of you probably already do informal cost analysis. You know what your programs cost per participant. The next step is to connect those costs to outcomes. And that's what moves you into value analysis, where you can really make some hard decisions if you have to. So for those just starting out, my advice is always get the cost data to be very solid first. You really can't do cost effectiveness analysis if you don't know what things cost. So start there. Practical tip. Cost effectiveness analysis, or CEA, it really does deserve special attention. It is heavily used in economic evaluation in public health, and so it actually is the subject of our next webinar, so in April. So understanding cost effectiveness, and here's what makes it different from other methods. You don't have to convert those health outcomes into dollars. You're expressing the results, the ratio. It's the cost per outcome. And just as an example of this, if a childhood vaccination program costs $500 per case of measles prevented, and a lead abatement program costs $20,000 per child protected from lead poisoning, and a diabetes prevention program costs $3,000 per case of diabetes prevented, those are not directly comparable because the outcomes are so different. So within each area, we can compare alternative approaches, but across them, we might want to know where should we be investing. And so a powerful measure in cost effectiveness analysis is the quality adjusted life year, or the QALY. It really combines the length of life and the quality of life into a single metric. And so one QALY equals 1 year of perfect health. And this lets you compare across different health conditions on a common scale. So if you are interested in learning more, we have not only the webinar in April, but a methods lab on our site that goes into more detail about this. But if anyone has done a cost effectiveness analysis in your department, or if you've done one in academic work and would like to share more about this, we can take a minute here and do that.
Thank you. I've done a few of these, and
You have.
it always seems to me like it's a great way to build and strengthen the team's discussion about what we're trying to achieve with the investment. Is it like, how are we measuring success? And then are there other facets or features that might matter? Because it seems to me that cost effectiveness is a great way of talking about the efficiency of getting to a destination, but
Mhm.
I don't think we do a lot of talking or focusing on is that the right destination? Are there other places we want to go? Has that been your experience?
I do find, yeah, I think it's easy to see where the need for cost effectiveness arises. And then it leads you right down the garden path to this broader question of where are we going? And are we using the right framework to pick priorities and to make these evaluations? Do you have advice for departments that are starting this process or thinking more about this analysis as they get started?
I would first, if people were thinking about potentially looking at the efficiency of what they do, then I would congratulate them because oftentimes it seems to me things are hectic and busy and you got to put out the fire and it doesn't really matter if you use 3 million gallons of water or just one fire extinguisher. You just don't want the place to get burned down. But if you do have the presence of mind to look at are you efficiently spending resources? First of all, good on you. And second of all, you're not alone. There's a lot of people who can help. You mentioned that there might be like a website that would have more information. You said a meth lab?
Oh, no, a methods lab.
Oh,
Sorry. Yes, on our caphegroup.org website, we have a resource page that has, I want to say, 32 methods labs. They
wow.
are really brief, uh, um, uh, really brief lessons on economics and public health. So none of them are very in depth, but they are useful introductions to these concepts. So.
If people wanted to try it, could they bring their idea to the CAPHE group and say, hey, we're thinking we want to look at, the cost effectiveness or the value of this new intervention so that we can get more support for it? Could they bring something like that to us and have help?
Absolutely. I think the group would be very enthusiastic about providing that kind of support. One of the things that we're launching actually this week, which I know we're already kind of at the end of the week, is a return on investment for public health spending at the county level, where people can request county specific reports, break down their spending, and talk about the effect on mortality within their county. So we're always happy to partner like that. Thank you. Great. Um, Segueing from cost effectiveness into the return on investment, ROI, it's a metric that I think policymakers do pay a lot of attention to, and I want to explain why and also sort of where to be careful about it. The formula here is pretty straightforward. It's benefit minus cost divided by cost. So if you invest $1 million and generate 5 million in benefits, your ROI is showing a very high rate of return in that sense. So every dollar returned generates 5 for every dollar invested. And so when you tell a county supervisor or a state legislature that number, they understand it immediately. It speaks the language of business and government budgeting. And so, as I mentioned before, what we are on our CAPHE group.org site have some research examining California's local health department spending, which suggests a very high rate of return per dollar invested in public health. Previous studies have put this at $67 to $88 back for every dollar spent. And so this update of this question using data through 2023 shows a rate of return as high as $125 per dollar invested when using current federal valuations. But it's a challenge, and I want to be really honest about that. This requires expressing health outcomes in dollar terms, and that means answering uncomfortable questions about what is a life saved worth. So the federal government uses a figure called the value of statistical life, which I think according to HHS is $13.6 million. But you may have seen recent Times articles that talk about other federal agencies not using a value of statistical life in calculating damages moving forward. It is a statistical measure based on how much people are willing to pay for small reductions in mortality risk. It's not saying an individual life is worth exactly that much. The naming is unfortunate, but it's really about how much we're willing to pay for small reductions in mortality risk. But it makes people uncomfortable, the methodology, and that's okay. Being transparent about these assumptions, I feel, is really important. And one of the things that we'll talk about in our June webinar on ROI is this very topic, and we'll dig into it a lot more deeply. But it is a potentially powerful advocacy tool as long as you're transparent about your assumptions, present ranges, and avoid, single numbers, pegging things to single numbers. Okay, so we've covered conceptual foundation. Now comes the part I think will be the most immediately useful, and how to actually apply these ideas in our work. So here are 6 situations, at least, where economic analysis can add practical value. And I am hoping that this aligns with situations that people have found in their own work. The first is comparing alternative programs. When you have evidence-based options for addressing something like youth mental health, an economic analysis can help you pick the one with the best outcome per dollar. The next one is justifying new funding instead of, leaving the argument as something like community health workers are evidence-based. You can talk about how, based on published cost effectiveness data, we estimate the program will cost $3,200 per emergency department visit averted, with a projected return of $4.50 per dollar invested over 3 years. That's a fundamentally different conversation. And then the other side of that being as a response to budget cut proposals. And this is where the economic thinking can become a bit more defensive. So when someone proposes budget cuts, showing the cost of inaction is incredibly helpful when having to make these decisions. So, showing the downstream costs if prevention services disappear um, is a key area where health economics can be used. Um, the fourth one is writing grants. Federal funders tend to are increasingly asking for cost effectiveness data, or at least a sustainability plan with economic reasoning. Reviewers are noticing when applicants can articulate the economic value of their proposed work. And finally, we alluded to this earlier, the strategic planning. We think about community health improvement plans and strategic plans, and they are stronger at times when they include economic criteria for prioritization, in addition to things like burden of disease ranking. And finally, the communicating with stakeholders, whether it's community advisory boards, the media, elected officials, all of these audiences respond to economic framing. And to say something like program saves lives is good. To be able to say the program saves lives at a cost of $15,000 per life year gained, which is below the cost effectiveness threshold, can be much more persuasive depending on the audience. I'd like to stop here and just ask if people find that these six resonate with their work, or if they have other situations where it's been useful.
I really like what you've listed here, and I imagine you can give examples from your current employment and maybe other experiences where they've come in handy. So it sounds like this health economics stuff is not only an academic, interesting theoretical exercise, but it could be really useful if you wanted your organization to have a strategic advantage in communicating its value. It sounds like that last bit at the bottom, the communicating value, it seems like you might need to study the value before you communicate it.
I think that's exactly right. Getting clear on what is the value, and how do things rank internally so it can be communicated to external stakeholders is probably the right order of operations here. And I would say just articulated our underlying thesis for this presentation so well. The idea that economic analysis is a way to sort of frame our decision making or make those decisions more transparent, but it's also a way to strategically implement really hard changes that may not be, necessarily within our control, for adapting how we respond to public health needs under different circumstances. So
That's really interesting what you just said. It makes me think there might be a skill set in helping people who are very comfortable with the notion of things either being more effective or less effective, and that being a compelling and perhaps sole prerequisite for doing something like, well, we've got to make funding cuts, but we can't cut this because this program is actually helping people, and we can't cut that because that's also helping people, and we can't. Um, do you have a way of communicating that helps people get beyond a single dimension of is this intervention just more effective or not? Especially if you have to cut.
yeah, I mean, I think we've talked about how identifying what the values are, the core values that we're optimizing, is really the first order. Economics can help figure out how close those decisions bring you to those values, but um, I don't know that I have what are your thoughts on how to sort of navigate closer to that optimal
Yeah, no,
optimization problem?
I like, it's a challenging question, and I feel like the topics that you've given us as you were building up help lay the path for this discussion. This using economic analysis is sort of like the final step, but the step before that is some compelling need for either having to cut or having to request. And then the notions you've introduced, like of marginal, like maybe if we cut every single program by 5%, We don't have a 5% decrement in all of the different things marginally, as you were speaking. Maybe if we cut one thing that's mission critical by 5%, then we lose 50% of whatever it is we're trying to do. Whereas if we cut a different program by 5%, we still lose, but we don't lose as much. So the concept of marginal, even though we're losing, we can still pick the hurt that is less, um, and protect what's core.
I think that's exactly right. And actually, I was in a meeting where we were talking about sort of the practical application or the practical ways in which we're asked to make budget cuts. And I think without, necessarily touching on this idea of marginal benefit, the most, senior person in the room was like, it's a mistake to cut everything by 10% across the board. It's better to make hard cuts and end some programs completely to preserve what is mission core to your mission. And I thought that is the economic intuition that we operate with in this space. And he didn't mention marginal benefit. He didn't talk about optimization, but it was all in the thinking. So I do think that the economic thinking is in public health. The economic analysis just sort of helps give it framework and a way of communicating it. So I'm going to move on to our next slide, but I'm really excited to continue this discussion. Some common pitfalls to avoid, because we've seen really well-intentioned economic analysis go wrong, and it's a good thing, the predictable ways, right? So if we know what to avoid, we can take that moving forward. The first is to ignore opportunity costs. Only counting direct program costs really loses some of the story about what it takes to actually produce services. And so when we talk about scaling up services or programs, if we haven't really fully captured that cost, we may be jeopardizing the success of that effort. This second is comparing apples to oranges. So programs with different outcomes, we do need a way of translating those across. And so I talked about a common measure like qualities or dollars, but we don't want to be in a position where we are presenting programs with completely different outcomes ranked side by side based on cost alone. That is a bit misleading because then there is no way to really judge the benefit in a fair way. The third one is overstating benefits or understating costs. And in advocacy, that can be kind of tempting, but it does long run destroy credibility. So if the analysis says a program returns $50 for every dollar invested and the actual result is half, or it only happens under a very specific set of conditions, we're not really setting ourselves up for success for scaling the program or spreading it into new areas. And so it can be better to just present a conservative estimate, offering a range. That's still honest, it's still compelling, to say something like, we estimate a return of between $20 to $50 per dollar spent, with a most likely value around $30. The fourth is that we can't ignore uncertainty. We have to account for it. It's related to the point above. That's sort of why economic analysis, they always involve assumptions, and we want to present sensitivity analyses, or at least acknowledge what would change our conclusion if it wasn't constant. So it's fair to say things like, this estimate assumes 80% program retention. If retention drops to 60, the cost per outcome increases by 40%. That's helpful for practical planning. And that does build on credibility. And finally, we don't want to forget about equity. We know that efficiency and equity are not the same thing. And this matters a lot in public health, where we think that, a program may be highly cost effective overall, and it could completely miss communities that need it the most. Mentioned a flu vaccine campaign that might prevent the most cases per dollar, but it might only target communities where uptake is fairly easy, and miss groups that are isolated or unable to access that information. So an equitable choice may be less efficient. Both matter. Report both. And I would say in public health, we need both. So it's good to have them present in the discussion. Here's a getting started, some practical tips, and I definitely want to open this up to our audience for input. I don't want people to leave this webinar thinking that was interesting, but I don't know what to do with it. So here are some things that you could get started with almost immediately if you wanted to see more of a health economics framework in your work. The first is to start with cost documentation. How much do programs actually cost? I know we have systems for tracking payroll and grant funding and things like that, but they may not always line up with how we think about program costs. They are tracking very specific streams across different systems, and so it may take some coordination and effort to get that cost data in a usable format for doing economic analysis. The second is to identify outcomes and how they're measured. So what does your program actually change? Is it cases prevented? Is it ED visits averted? Is it qualities gained? Um, if you don't have outcome data, can you use published estimates from similar programs? Being aware of what's already out in the space can be helpful. Similarly, three is to look for cost effectiveness studies that have been published. Before you do your own analysis, you can check what's already been published. There's the Tufts Cost Effectiveness Analysis Registry that has thousands of published ratios. If someone has already studied a program like yours, you can cite their findings. You can reach out to them to see if they have any advice on structuring your own cost effectiveness analysis study. And this segues into my fourth point, which is partner with academics. Um, there are health economic faculty across a range of institutions, some present with us today, who have, a well-respected research base in this field and do practice-based research partnerships. Um, our group can help make some of those introductions. We also have members who consult with county departments on economic analyses. And so reaching out to get support for what's happening within your department is a viable strategy. And finally, or fifth, I seem to like lists that end in five, and yet I've included several that have six things. Use existing tools and templates. There are cost analysis toolkits offered by the CDC. The World Health Organization has DEA guidelines. And as I mentioned before, CAPHE has a methods lab tutorial and a return on investment calculator. So you don't necessarily need to reinvent the wheel to get some of this analysis in place. And this is my favorite, actually. Don't let perfect be the enemy of good enough. At the back of the envelope, cost per participant estimate that takes you 30 minutes is far more valuable than a perfect analysis you never have time to do. Start rough, refine as you later, and the goal is just to build a habit of economic thinking, not to publish in a journal and then just build there. I'll pause there and open it to others to offer their thoughts on how to get started from a practical standpoint.
I think this looks like great advice and practical tips. Um, I wonder, um, what do you when you're thinking about your day to day and your practical, what do you see as the number one obstacle preventing more doing of this? Is it that we don't have everything we need and it's perfection that's slowing us down, or are we not employing economic thinking, not thinking we can only spend that resource once, so what's the best way to spend it? Or is it difficulty finding either article templates or academics?
That is a very good question. I will say from my personal experience, I think it's not not seeing the opportunities for how we move from cost analysis into the economic analysis piece. So
Well,
from
wait
that
a minute, wait a
left-hand
minute.
column.
Yeah, what's the
Mhm.
difference between the cost analysis and the economic analysis?
Yeah, so thank you. I think it's a little bit about people have a sense of what their programs cost. what they hope the impact is. But there's a sense that there's not enough time to measure those medium to long-term impacts before the program wraps up and moves into the next piece. And we think about the economic analysis of what these programs do, we are thinking about how do we map out what was done to those longer term effects. And I think it's important, if we are doing this work, to talk to the people who are doing the work, those who are delivering the services. I, there's an article, How to Build Economic Models in Your Spare Time, that came out in 1994, that I think still holds true today. And it is all about how it is about having conversations with people. It is about looking for the economics underlying the realities of how we approach our daily work. And I think that those communication frictions are probably our biggest challenge in doing some of this work. What about for you? What has been your experience?
I really liked your answers to that. I would say a lot of the inertia is the last bullet you have there, the perfection. Um, Especially, and I love what you said about how maybe we could just try. For example, we might want lifetime outcomes if we can get people to stop smoking. Maybe they'll be a little less dead, or maybe they'll be a little bit more healthy, or something like that. But we may not have the resources, the time to go 60 years into the future. But maybe it's okay just to measure what we do have, like a proximal outcome. It's good enough for now, and then later we can get fancy with it. So it's sort of like, for me, the antidote becomes trying to do the best we can with what we have. Realizing that whether or not we have the evidence to make the decision, we're going to have to make choices because of all that you had talked about with the scarcity and the opportunity cost. And so, yeah, maybe the evidence is not perfection, but maybe learning a little bit about what we can from what we have. Maybe that's, like you said, good enough for what we need to get done.
I think that's right. And I think the cost curve for accumulating data it's shifted so significantly. Oh, thank you. The link. I will also add that link to our follow-up. But I think the cost of collecting data has shifted so significantly in ways that even 5 years ago we couldn't have predicted. And so agonizing over assembling the perfect data set is almost a wasted effort, because down the line it may be easier. But if we need information now, then we should use what we have now to do that. So that's a really excellent point. Um, we're almost at time, so I'm going to move forward and just share some resources here, and I will circulate some. Um, I'll add to this page when we post it. But there are the free interactive tutorials on health economics methods that are posted on the site. There's also the opportunity for monthly peer review, when you can get feedback on different analysis from the group. Professional membership is also an option. It allows for more access to advanced labs and working groups. And then the webinar series, which our next two are scheduled for April 9th and June 11th, and we'll be continuing them throughout the year. I would encourage people to stay connected. We love hearing from people and definitely providing support where we can. And so here are a few ways to stay connected, either through our newsletter, sending specific questions, or coming to webinars that are scheduled for the future. Thank you. I'll open it up to any questions. I'm going to